Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm excited to bring to you a conversation that revolves around one of my favorite topics. And it's one that I think often receives too little attention in our profession. Today, our guest is Gerard Farrell. He earned an entry-level physiotherapy degree from the University of Otago in New Zealand. Also from the University of Otago, he earned a sports physiotherapy certificate and diploma, as well as a Master of Physiotherapy endorsed in orthopedic manipulative therapy. Most recently, Gerard completed his PhD training. He is currently one of the third-year and postgraduate student clinical supervisors at the School of Physiotherapy Clinics at the University of Otago. We invited him to the podcast today because he was the primary author of a paper recently published in the Journal of Manual and Manipulative Therapy. The title of the paper was Autonomic Nervous System and Endocrine System Response to Upper and Lower Cervical Spine Mobilization in Healthy Male Adults, a randomized crossover trial. I'm excited for this conversation, and I hope you are too. So, without any further delay, let's get to the interview. Gerard, welcome to the podcast. How are you today?
Good. And yourself?
I am doing spectacularly well. Thank you for asking. And thank you for joining the podcast today. By the way, also congratulations on this paper. I found it to be a very interesting read, and as I said in the introduction, it happens to be one of my favorite topics. So I'm really excited to have you on the show today.
Cool. Thank you for the invite too. This should be quite fun discussing the mechanisms of manual therapy.
I agree completely. And let's start off with what I think is a relatively simple but important question. And that is, what got you interested in the autonomic nervous system and endocrine function as it relates to manual therapy? And I guess we could say, in other words, what was the seed that was planted in you that helped you lead to your PhD work?
Yeah, good question. A little bit of a long-winded answer, but sort of just to be sort of fully honest with it. So back in 2017, when I was doing my master's degree, I was exposed to the mechanisms of manual therapy when sort of doing the manipulative component of the degree. And before then, I'd sort of really just considered the more biomechanical or more sort of pain mechanisms, not so much the endocrine and the autonomic mechanisms. So I was exposed to this during this paper, and we sort of learned about it, we tested on it. And then I went back to my clinic in Australia at the time, and I started obviously treating patients. And it was interesting because I was still probably treating patients with the thought of the biomechanical and pain mechanisms. But I was starting to sort of notice and started to see some responses which weren't quite fitting with those mechanisms. They were more fitting with the autonomic and endocrine system. One of the sort of key patients I saw, and actually the catalyst of my whole thesis, was this guy who had a concussion 6 weeks earlier when playing Aussie rules football. He got better for the first week, but then for the next 5 or so weeks, he hadn't really had any change in his symptoms. So he'd seen a bunch of other health professionals to sort of see what's going on. Anyway, this person worked quite close to me, so he came in to see me to treat sort of upper cervical spine sort of ache and stiffness that he had, which would sort of bring on a little bit of a headache. Really, he just wanted this sort of stiffness and ache to be treated. He wasn't too concerned about the other symptoms from me. Anyway, so I treated him, assessed him, then treated him for specifically some C1-2 stiffness on the right side. His range of motion improved, the sort of ache was gone. But what was interesting, and I only found this out later, is that afternoon he went back to work and he didn't have to go home early. He didn't get the normal light sensitivity that he gets, which leads to a headache. And then that night he was able to train Aussie rules football full session. Whereas previously, could only really jog 100 meters and then he'd start getting sort of headaches and nausea and would have to stop. So I was really interested why all those other symptoms, light sensitivity, exercise tolerance, improved simply really after just doing an upper cervical spine mobilization. So I finished my master's degree and I was out. I was done with research. But then 3 months later, I thought, oh, no, I'm keen to sort of see what this PhD thing is about. So I contacted my primary supervisor throughout my PhD, who exposed me to the other mechanisms, Associate Professor Steve Tumulty, and we started just talking about PhDs. We got talking about the clinic. This patient came up, and that was pretty much the catalyst for doing the PhD, which is looking into the autonomic and endocrine mechanisms of manual therapy.
Thank you for that answer. That was great. And I really like the point about using a patient's response to help inform us when it comes time to think about a topic like mechanisms. Of course, we're all aware of the fact that in the end, patients really should be the primary reason that we're in this line of work. If we're not doing this for the patients, then, quite frankly, why are we here?
Yeah, I definitely agree with that. Clinically informed questions really help guide strong research and, meaningful research.
And with respect to the published study that we're talking about today, can you talk about the importance of the stress response, how you define it, and how it works physiologically?
So, bit of a long answer coming up here. In essence, the stress response is the human body's response to any stressor that we're exposed to. So, it's the physiological and the behavioral response to stress. Now, stresses can come in many forms. So, we can have physical stresses such as a musculoskeletal injury, trauma, or concussion, for example. We can have physiological stresses such as a virus or an illness. And we can also have psychological stresses such as stressful upbringing, early loss of a parent, for example, or a stressful work environment. So, this stress response is what our body uses to respond to these stresses. And it has a very important evolutionary perspective because if we didn't have the appropriate stress response, say 2,000 years ago, we would really have struggled with running away from wild animals, famine, starvation. And that response has obviously continued through now, where we're maybe not exposed to those things as much, but we're still exposed to stresses in everyday life. So, what is the stress response? Well, to sort of just open it up a little bit, it's the stress response is mediated by the whole stress system, which has central components, peripheral components, and also the sort of organs that it controls. So, now going from the stress system to the stress response, the stress response has the central components, which consist of structures such as the prefrontal cortex, the limbic system, including the hippocampus and amygdala, and they sort of lead on to the peripheral stress response, which is the main thing I'm going to be talking about. So, the peripheral stress response consists of the autonomic nervous system and the endocrine system, specifically the hypothalamic pituitary adrenal axis. Now, I know that's a bit of a mouthful, and I'll try and sort of explain this a bit further. So, going to the autonomic nervous system component of the stress response, we've got the sympathetic nervous system, which is our fight or flight response. And we've also got the parasympathetic nervous system, which is our rest and digest response. Now, those two systems really sort of work as a seesaw. They're interrelated, they work together, they work bidirectionally. Let's go to the endocrine component of the stress response, the hypothalamic pituitary adrenal axis. This is the part of the response that releases that stress hormone, cortisol, which as physios, we probably know a bit about, sort of like steroid injections, a potent anti-inflammatory. But cortisol has a lot more widespread functions across the body, and one of the particular ones is its sort of modulation of stress or the stress response. These components of the stress response, the autonomic nervous system and the hypothalamic pituitary adrenal axis, they're interrelated, they sort of interconnect, and they can work bidirectionally. And those components, they are tonically active. So I'm sitting here right now, you're sitting here, Stephen. Those components are just working in the background to make sure you're ready to go if a stressor comes. And then if a stressor does come along, that response is able to be activated. So what happens when the stress response is activated? Initially, the autonomic nervous system, the sort of neural component, fires off. That's the fast-acting but more shorter-lived component of the stress response. which then communicates with the HPA axis, which is the slower acting but longer lasting component of the stress response. This response, if you're chronically exposed to stress, or if components of that stress response have been sort of injured or sort of stressed or sort of damaged, such as what can happen in a brain injury or concussion, your stress response might not work as well, or might not be as efficient. And how that will present is either an altered baseline of stress or an altered response to stress. So an altered baseline to stress might present with sort of a heightened or dampened response. So how someone might present with a heightened response is that they might be sort of more irritable, they might have insomnia, they might be a bit more anxious. Whereas someone with a dampened response might be more lethargic, more apathetic, or sort of have a lack of interest, might have a bit more fatigue. And someone with a heightened response to stress, they might present with, let's sort of use an example with that. Let's say, for example, someone, this is actually a real example, someone's walking down the stairs and they roll their ankle inwards. This particular person who did that, once they sort of processed that they've rolled their ankle, got quite pale and fainted. So I would say with that particular person, there was quite a heightened response to stress. Whereas if you think of other sort of scenarios, maybe someone would do the same mechanism, see it and be like, oh, yep, it's okay, no issues, and be just real calm about it and not really take too much notice of it. But they may have required to take notice of it because now they've injured their ankle and they've sort of been walking around on it, not caring too much, and they've sort of really impaired that initial phase of healing, which is quite important when you want to try to protect that area within reason. So that's sort of a bit of an overview of the stress response. And what I've used in this study is I've only looked at the peripheral components of the stress response, so the autonomic nervous system and the hypothalamic pituitary adrenal axis. For this study, we've looked at the peripheral components of the stress response being the hypothalamic pituitary adrenal axis and the autonomic nervous system, and we're seeing how manual therapy applied to either the upper or lower cervical spine can modulate those components, or if they can modulate those components of the stress response in healthy individuals. So just to summarize, the stress response is tonically active in everyone, and it's there to respond to stresses. This stress response can become dysfunctional, which can lead to sort of subtle signs and symptoms, either at baseline or in response to stress. And this mechanism could potentially be one of the reasons why, for example, concussion, which was my PhD, why some people with concussion might have persistent symptoms.
Excellent. Thank you for that nice review of the physiology of the stress response. My guess is that most of our listeners could benefit from that review. Now, based on your knowledge of manual therapy and human physiological function, which measures of physiological function did you decide to utilize in this study, and why did you pick those particular units of measure?
Good question. So for the study, as we mentioned in the previous answer, we were looking at the peripheral components of the stress response, the autonomic nervous system and the HPA axis. With regards to the autonomic nervous system, we've got the sympathetic component and the parasympathetic component. For this study, we focused more on the parasympathetic component with the outcome of heart rate variability. The reason we chose heart rate variability was partly because it's a clinical measure. People can take their heart rate variability just with their smartphone, and that's what we used in this study. And we wanted to try keep it as clinical as possible. But also, we chose heart rate variability too because the parasympathetic nervous system has quite a large control over the sympathetic nervous system, particularly on the heart, where the parasympathetic nervous system sort of acts as a throttle, whereas if it increases its activity, the heart rate decreases, or if the parasympathetic nervous system decreases its activity, the heart rate increases. So just sort of a little bit of a summary of heart rate variability. It is a measure of parasympathetic nervous system activation. So what heart rate variability is, it's the difference between consecutive heartbeats. So if I'm sitting here right now and my average heart rate is 60 beats per minute, Within each of those 60 beats, there's going to be subtle differences. That's the heart rate variability. And ideally, you want a higher heart rate variability, so more differences between those heartbeats, because that indicates your parasympathetic nervous system, your sort of baseline sort of stress levels, which will be controlled by the parasympathetic nervous system somewhat, is working well. And the reason that is because the vagus nerve, which runs from your brainstem across the front of C1 and down into the heart, the main parasympathetic nerve, cranial nerve, is one of the key controllers of heart rate variability, because that's what leads to the quick changes in heart rate. The mobilizations we applied were to the upper cervical spine, which we think would be stimulating that vagus nerve because of its relationship with C1. So in summary, for the autonomic nervous system, we used heart rate variability. For the hypothalamic pituitary adrenal axis, the endocrine component of the stress response, the end product of that axis is cortisol. So the outcome that we used for this paper was cortisol measured with saliva.
Perfect. Thank you for that explanation. As I'm sure most of our listeners know, there are a lot of different ways to measure function as it relates to the autonomic nervous system. So, of course, it's therefore important to understand the outcomes you used in order to understand the study. Speaking of which, can you talk at greater length about the design of the study, as well as why you chose that particular design for this investigation?
Yeah, so the design of the study was a randomized controlled crossover trial. Now, why we chose crossover trial over a parallel design, for example, is that the crossover trial means that each individual can act as their own control. So what we did in this study is that we had the 20 participants, and each participant received upper cervical spine mobilization and lower cervical spine mobilization, separated by a 1-week washout period. So if you received upper mobilization first, you'd then receive lower cervical spine mobilization a week later. Whereas if you received lower first, you'd get upper cervical spine mobilization the week later on the same day, same time, to sort of minimize the environmental effects. Why it was good to have a crossover trial is because the outcomes we chose, salivary cortisol and heart rate variability, which are proxy measures of the autonomic and endocrine components of the stress response. The stress response is modulated by so many different sort of factors and levels. So people's age, diet, conditions, underlying stress levels, their general underlying physiology. To try and control for that as strongly as possible, it's best to use the same individuals for the different interventions, because that takes into account those different sort of factors as well as we possibly can. The other reason we were allowed to do it was okay to do a crossover trial is that there shouldn't be a carryover effect on healthy individuals receiving these interventions. Previous studies which have sort of looked at similar types of outcomes on healthy individuals showed that the response only lasted minutes to hours afterwards. So when we're talking about a week crossover, so washout period like we used in this trial, that should be ample. And we did compare the baselines pre-intervention at the different time points after a week washout, and there was no difference. So we didn't have a carryover effect or a sequence or period effect.
And during that process, who were the subjects in the study, and why did you define your inclusion and exclusion criteria in the way that you did?
So the subjects in the study were healthy males, aged between 21 and 35, with no current pain, illness, or injuries. So the big elephant in the room is only including males in the study and excluding females from the study. So the reason that decision was made is because to get the strongest internal validity for this particular study with these outcomes, you couldn't have both sexes in the same study, because our outcomes, sort of the autonomic nervous system and the hypothalamic pituitary adrenal axis, modulated differently between the sexes. And the reason we chose males is because of more of a time and funding restraints, because if you wanted the strongest study design to measure females, you would do the interventions at the same phase and the same time of the menstrual cycle. And that's because the different phases of the menstrual cycle and sort of the hormone changes affect the autonomic nervous system and endocrine system differentially. So you'd want to perform the intervention at the same time, same phase of that month, and then have a month washout period to make sure you're in that same phase, same time the month later. And that would have just taken a little bit too much time within the restraints of the thesis. So unfortunately, we had to exclude females and just keep males in this study. Now, the age range of 21 to 35. So age is a big confounder on the components of the stress response. So up until the age of 20, our autonomic nervous system, endocrine system is developing. And then pretty much after the age of 35, it's on the decline. So that's why 21 to 35 was chosen as the age range. And we wanted individuals that were that sort of had no current pain, illness, or injuries, because if they did have any of them, it means that their body's in a state of stress, and so their baseline stress response and their sort of the reactivity, their response to the intervention would probably be different. So we had to keep it as just healthy individuals. And that's sort of why we also excluded people that had any cardiovascular, endocrine, they were on any medications, because we wanted to control for that stress response as well as and sort of the confounders of the stress response as well as we could. We also had to make sure that we screened individuals for mobilization. So if they had any contraindications to manual therapy, they were excluded. And if they had any precautions, it was on a case-by-case basis if they'd be included or not.
Excellent. Thank you for that description. And especially thank you for diving into the whole male versus female topic, because I was going to come back at you with a question about that. Your explanation, however, makes a whole lot of sense. Now, let's get to the most interesting topic. Tell us about the manual therapy techniques that were applied and what responses you saw in the subjects during the study.
This is definitely the interesting one. Okay, so the manual therapy techniques that we applied are probably not the most conventional manual therapy techniques, but I will explain this. So what they were low frequency, mid-range, bilateral, alternating oscillations or mobilizations applied to either upper cervical spine, so C01 or C12, or C01 and C12, and then the lower group, the mobilizations were applied to C67 and C7T1. So to sort of just put a picture in everyone's mind of the position we're in with these mobilizations, let's describe the mobilization I did to C01. So the subject is supine. I have my hands under their occiput. My index finger is on the transverse process of the right. So one index finger is on the transverse process of the right C1, and the other is on the transverse process on the left C1, with my middle finger supporting it. And then I'm applying sort of roughly 3 Hertz mobilization side in an oscillating manner. Now, why the 3 Hertz was chosen was because the low frequency mobilizations, sort of the 1 to 3 Hertz, is what the autonomic nervous system sort of delta brainwave activity, which is associated with autonomic nervous system processing, occurs at low frequencies, 1 to 3 Hertz. So we applied the mobilizations at 3 Hertz because that provides more of an autonomic nervous system stimulant. And why we did this in the supine position without the head, or without using the head to rotate, the head rotating around, is because in the concussion populations, often they have a vestibular component, and applying a mobilization at sort of a 3 Hertz frequency, that can be a bit irritating to someone with a vestibular component. So we wanted to try and mobilize the same level, but with keeping the head still. And that's sort of where these mobilizations came from. Now, I've got to put a disclaimer in here. I did not invent these mobilizations. Associate Professor Steve Tumulty did. And when we were teaching together in 2021, we were showing these mobilizations to the postgraduate class, and one of the students asked, well, how do you write this in the notes? And Steve was like, well, you'd write low frequency, mid-range, bilateral alternating oscillations. And the students were like, well, that's a handful. Can it not be shortened? And then one of the other students just joked, oh, you should call them the Steve Tumulty mobilizations. And then that got shortened to the ST mobilizations. So I guess if you want to write it in the notes, Steve will kill me for saying this, or even just mentioning ST mobilizations, but I think he deserves credit. So just put ST mobilizations in your notes. Anyway, let's get on to the results. So I've just got to put a disclaimer in here. When you're trying to talk about the stress response, that's not the easiest thing to try and talk about if it's sort of one of the first times you've heard of it, or it's sort of fresh knowledge. But then trying to talk about different mobilization locations at different time points doing different things to hormones in the autonomic nervous system, it's not the easiest thing to explain. So what I'm going to do is I will sort of explain the key results of this study and just try and bring in some clinical relevance to it as well. So what we found after lower cervical spine mobilizations is that there was a statistically significant decrease in cortisol levels 30 minutes after the mobilization, which indicates that there is a decrease in the HPA axis activity 30 minutes after those mobilizations, which one may say is a dampened or decreased stress response. This was an interesting response because it wasn't what we expected. We hypothesized that lower cervical spine mobilizations would increase cortisol levels because the lower cervical spine is where the sympathetic nervous system ganglion lives. However, what we found the night after the intervention is that cortisol levels increased after lower cervical spine mobilizations. This makes sense because, as we talked about in sort of the sort of second or third question, the stress response, the endocrine component of the stress response, is the slower acting but longer lasting component. So we found that there was an initial decrease in cortisol levels, but when you consider the main function of the stress response, the longer lasting component, that night after the intervention, there was an increase in cortisol level, or a trend for an increase in cortisol levels. So that wasn't statistically significant, but there were quite wide confidence intervals, and it's definitely a trend sort of worth explaining and exploring, because the clinical relevance of that is certain populations, such as persistent post-concussion symptoms or long COVID populations, their sort of underlying pathophysiology can be low cortisol levels. So maybe lower cervical spine mobilization could be quite a good treatment for those populations to help increase their cortisol levels. Now, what we found with the autonomic nervous system, again, although not statistically significant, was quite an interesting trend going from pre to 5 minutes post the intervention. So what we found 5 minutes after upper cervical spine mobilizations was that there was an increase in heart rate variability after the upper cervical spine mobilizations, indicating an increase in parasympathetic nervous system activity. That fits our hypothesis of the upper cervical spine stimulating the parasympathetic nervous system because of the location of the upper cervical spine and the cranial nerves, specifically that vagus nerve, which controls sort of a lot of functions, but particularly cardiac control, so heart rate variability. But what was also interesting is that what I just mentioned, upper cervical spine mobilizations increased heart rate variability, but lower cervical spine mobilizations decreased heart rate variability 5 minutes after the intervention. There was a trend for a decrease in heart rate variability, which again is what we hypothesized, that the lower cervical spine is in close proximity to the sympathetic ganglion, which should lead to a more sympathetic response, which means a sort of reciprocal decrease in parasympathetic response. So if upper cervical spine mobilizations, there's a trend for an increase in parasympathetic activity and a trend for a decrease in parasympathetic activity following lower cervical spine mobilizations, although not statistically significant, that fits in with sort of the function of the stress response, the autonomic nervous system function of the stress response, which is the fast-acting component. So I guess the question with this and what sort of leading with it is, if we got these initial changes, and there's a trend for this, clearly a study with a larger sample size would be good, but also what could you do to increase the response? So upper cervical spine mobilizations led to an increase in parasympathetic activity. And there's quite a few populations who would benefit from an increase in parasympathetic nervous system activity, such as, again, persistent post-concussion symptoms, but also populations like POTS, postural orthostatic tachycardia syndrome, who can be characterized by a lower parasympathetic activation. So what could you? So really, you want to know, like, what could you do to just increase that response?
That was wonderful. Thank you for that answer. And you really kind of preempted my next question, which was going to be about clinical practice. So thank you for working in all of those examples about how a clinician can read a study like this one, take away information that's been presented, and then apply it in different ways to different populations. Because as we said before, I mean, that's really why we're here in the profession. We're here to make patients better. Now, this was a relatively unique study, and as we've mentioned repetitively, it was conducted on healthy subjects. As you've already partially mentioned, this tells me that there's a lot of room left over for follow-up studies. Do you have anything planned? Maybe a follow-up study on female subjects, or maybe on subjects with painful pathologies? And even if you yourself are not planning on any additional studies after this one, what would you like to see show up in the literature in terms of the next step in this line of investigation?
Yeah, good question. So you've hit the nail on the head, really there. This study was done on healthy populations. So definitely the next step is to apply these mobilizations on symptomatic populations and see what happens, or what the response is in those populations. Just as a bit of a carrot, that's exactly what I've done in my thesis. It's just unpublished at the moment. I'm sort of shortening an 8,500 word chapter to 3,500 words to get this article off. But we effectively did the same treatment on a population with persistent post-concussion symptoms. So watch the space. And definitely this has to be done on the female population. Over half the population in the world is female. So removing the time restraints of the PhD, definitely the next studies will be including female participants. The other thing too, and sort of some other sort of thoughts on where to go next, is the peripheral stress response modulates many different systems or organs. So downstream to the stress response, you want to look at what else happens on particularly the immune system or the inflammatory markers. That's definitely an untapped area in manual therapy research, which I'd be very interested to sort of look into. Again, some gastrointestinal markers because of the response of sort of the ANS and the gastrointestinal system, the nociceptive system, but also including the sympathetic nervous system too. So really, if you want to gain a true understanding of the stress response and its effect, you want to try and include a lot of different markers. And one of the good things is that saliva can actually be used to measure the sympathetic nervous system, the immune system, but also the nociceptive system as well through some of the biomarkers in there. So it's quite a good objective measure for that. The other thing too is that since we're sort of talking about the stress response and we want to apply it to clinical populations, at the moment, what I was talking about with how to identify a sort of heightened or dampened response is that's based on like strong neuroanatomical, neurophysiological, neuropathological principles. But research needs to be done to see what people with a heightened stress response presents with compared to someone with a dampened stress response and how they might present. So sort of what I'm going at, for example, there, let's say, and this will be sort of the persistent post-concussion symptoms population. If someone comes in and they've sort of got light sensitivity, but they're also complaining of maybe like dry, scratchy eyes, you might say that they're in a more sympathetically dominant state. because the sympathetic nervous system will sort of reduce the fluid to the eyes to increase clarity so you can get away from the tiger, but also increase dilation of the pupils so you can get more light in and sort of just observe. So there's strong principles, but you need to get research on that at the moment. So if we now know that, once we've got the symptoms that can indicate a heightened or dampened response, what you've got to go next is you've got to link the treatment to the heightened or dampened response. We've got some pretty good idea of some of the mechanisms of interventions, so manual therapy being one of them, but also exercise therapy, like vagus nerve stimulation as well, cold water immersion. All those different treatments have different mechanisms. So if you understand the mechanism of your treatment and you can apply it to the particular symptoms, that would be another good study to see, does someone with a heightened response, for example, respond to an intervention that dampens the response? And does that response lead to clinical outcomes as well? Because it's really important. This study that we've talked about today is looking at the physiological outcomes, but you need to correlate that to the clinical outcomes as well. And does it work? And then sort of following all of that, I think developing, because this isn't the most easiest thing to digest, but if you could develop some type of an outcome measure which helps classify people into either a heightened or dampened response, and then it sort of links those responses to particular interventions that can help modulate it in different directions, I think that would be quite powerful. There's already one for pain, so the neuropathic pain symptom inventory, which sort of asks people questions about their pain and then guides particular sort of tailored interventions to their pain. And I think that would be quite a good thing to have for this stress response phenomenon that we're talking about.
Well, this is one of my favorite topics within our profession, so I will certainly look forward to seeing those studies in the future. That point aside, Gerard, I've really enjoyed this conversation, and I appreciate this type of addition to the available body of evidence that we already have. So thank you for bringing your expertise in research to the podcast and to our audience.
Thank you, Stephen. No, it's been a pleasure.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.